Hi, everyone, and welcome to another week in MHA626, where our topic this week, actually one of my favorite topics, is issues at the end of life. And I'll sort of go on to a little bit in this lecture of why it's one of my favorite. It actually is connected to the research that I'm doing, have been doing for a while. There's a number of things that I'd like to share with you in this lecture. First, I just want to point out, in case you're not aware, let me go back to that. This is a Ford Pinto, and two things about the Ford Pinto. One, it's the first vehicle I ever purchased. Not this exact one. I think it was silver. I was young. I think I might have bought it for $500. I was thrilled to have my own car. It, if you know the history of the Ford Pinto, and it's not too hard to research, as a vehicle, it's had its fair share of issues until it was essentially canceled in terms of Ford production because all kinds of things kept happening. Gas tanks were blowing up, engines were catching on fire. I don't think I had any of those issues personally, but it did tend to break down. And so oftentimes you'll see Ford Pinto connections to issues at the end of life when things just continuously break down. And I'm not talking about an individual's physical state or cognitive state, but as we go forward, keep the Ford Pinto analogy in your mind. So let's start with this. At the end of this module, hopefully you'll be able to discuss the impact of end of life and termination of care issues from, again, three perspectives: an organizational perspective, a provider perspective, and specifically for the user, and I'm going to also add family as well. So this is very much connected and highlighted in conjunction with the legal and ethical issues that we've been talking about in this class. And there's a variety of issues that need to be considered. As we've already discussed in the consent topic, assessing decision-making capacity is key because oftentimes in end-of-life care issues, the individual in question, let's just say the patient, is unable to make decisions, unable to comprehend because of the status, or it fluctuates. And so the issues in play, and we will start with decision-making capacity, because if an individual can make some sort of choice, then oftentimes decisions can be made. However, there are issues that flow from the end-of-life care arena, withholding, withdrawing care as well. Two different aspects of, or withholding and withdrawing treatment, I'm sorry. Certainly the withdrawing treatment, you're at a different stage than just withholding. But accompanied with that, and some of the treatment involves artificial nutrition or hydration, water. But then you get to a point where this becomes a word that is used quite a bit. Is the situation futile? Is futility involved? Now that's a fairly important step to get to, but it all has to be circled around the notion of, do burdens outweigh benefits? Burdens, certainly physical burdens, but also emotional, absolute financial, but also the trust in the healthcare system and professionals. And so this cartoon that you see here, the elephant in the room, this really, when it comes to these types of issues, it might not be all, we're talking about an individual at the end of life or approaching the end of life or even thinking about it, um, there are lots of, the elephant in the room has to do with all of these issues. And so this occurs certainly in, we think about a location where this typically occurs in emergency type areas, certainly in intensive care unit, but also in skilled nursing facilities, but more and more as individuals are living at home, um, but still dealing with their physical or cognitive ailments, it becomes an issue for the entire family. But even if you back up, where, let's say, the physical and cognitive state isn't in a state of crisis, um, individuals close to the patient can see the decline. I'd like to present a case to you. It's a case that has all kinds of issues to it, just to sort of circle around the issues at the end of life. And so let me read through the case and sort of highlight a few things, and I'll take some notes as well, just to present the topic. So we have an 88-year-old male with a history of pancreatic cancer, which has metastasized to the liver and abdominal wall. It sort of crept into the liver and abdominal area. End-stage renal disease as well, which means the kidneys aren't functioning and requires regular dialysis. And there's also recurrent respiratory failure. This gentleman is pretty sick. He's been in the hospital for 6 months, mostly in the intensive care unit on mechanical ventilation, sedation, and artificial nutrition, using a lot of resources, needing a lot of resources just to be alive as well. Unresponsive, unable to decide for himself, so unable to make any type of decision. So that first part, this is pretty bad, obviously. But the second paragraph here highlights really where the family, second and third, is. And we say family is dysfunctional. It's a pretty strong word, divided and manipulative. That could be the judgment of the healthcare professionals. But they insist that all should be done expecting a miracle and healing through faith. Now, is that, as you first see this, my sense is, at least if it was me, that given what's in the first paragraph, it seems a little far-fetched. Um, it seems that perhaps family members are not um, realizing the extent of the gentleman's condition. But there's always more to unpack. Uh, because what we see is that the children are professionals. One daughter's a judge, very educated as well. But they all say that life is precious and is fighting to live. And so they've made the determination, or it's made the determination, that they stay a full code. A full code, another way to translate that is if the gentleman's heart stops, he will receive CPR. The opposite of that is do not resuscitate, which you've probably heard before. But full code is the condition that's applied to that healthcare organizations use, determines one's status if their heart stops beating. The last paragraph talks about his next of kin, essentially the individual who will make decisions if he is unable to, and as we know, he's unable to, and it's his second wife, but she's intimidated and threatened by the powerful older children, and she's even younger than them and unwilling and unable to go against their wishes. So, what do we do with this? Now, let me highlight that for individuals who, um, this is a pretty bad case, but it's more common than you would think. It's more common for a variety of reasons. So let's take some notes here. I'm going to move my. Sorry about that. Just so I can take some notes. What we see is this gentleman is unable to make decisions. And so it has to be made by others. And yet, we don't know if any type of conversation or advance directive, and I'm going to talk about that in a second, has been done in the past. So it naturally will fall to his wife. And as we know, she's intimidated, unwilling, unable to make decisions because there are adult children involved who obviously have some sort of say in this. Now, these are more statutory legal issues. Who can make a decision? Well, it's the wife. Who's able to make a decision? Well, that's a different question. What we know is the healthcare professionals have to act on something, and they are essentially in the middle of this, so we have the patient over here, we have the healthcare professionals over here, and we have the family here. This sort of looks like a bullseye. So we have the patient, healthcare professionals who are treating the patient, and then we have family over here. And this is really a image. I'm not a great artist, that I tend to use a lot because it's back and forth between the family and the healthcare professionals because the patient is unable to respond. And the goal, of course, is always to provide the best options for the person in the middle, the patient. But there are family issues, as all families have issues. And those issues are highlighted and exacerbated in a moment of crisis. It is the wrong time to deal with family issues. In essence, if I can use a great ethical term, this is a mess. And yet decisions have to be made, certainly because there are physical, emotional, and certainly financial burdens. With the inability for, let's say, parties to take the lead, it will fall on recommendations by the healthcare professionals, perhaps through some sort of consult, an ethics consult, because the situation on behalf of the gentleman cannot continue as it is. In fact, it's gone on too long. And so the case in point here is, in order to minimize this, and let's say perhaps even to avoid it, what is becoming more readily available, and it coincides with a lot of the work that I've been doing in terms of my research, has to do with advanced care planning, planning in advance. And so we're ahead of a crisis. The fundamental question of what matters most to you is asked. And so I'd like to introduce you to elements of advanced care planning and invite you a little bit later on in this to participate in an exercise. So for a number of years here at USI, we've been really doing, I think, some good work in the community and with healthcare organizations in the area of advanced care planning and asking the fundamental question, what matters most to you? This scenario that you see in front of you, we call the sudden event scenario, is part of the education and the training that we ask individuals to go through before a crisis is before they're experiencing a crisis. And so this scenario here, where an individual's in a car accident or illness like a stroke and has left them unable to communicate, they're receiving all the care they need to keep alive. The physicians believe there's little chance that they'll ever recover the ability to know who you are, who you're with. This is the scenario. And then we ask these two questions over here. The purpose in asking these questions and having individuals reflect on this, discuss it, is so they can put the scenario in their mind in advance. Hopefully, the scenario will never occur. Oh, sorry about that. But it's really thinking about, so reflection, discussion, and then perhaps documentation through some sort of advanced directive ahead of time. This is the process of advanced care planning. And of course, sharing that. Now, I don't necessarily want to go back to the gentleman because he has so many medical issues, but wouldn't it be useful to have these conversations, perhaps almost for an adult at any age, over the course of one's lifetime, where you could think about something like that and then communicate it to family or friends or a healthcare professional? And so we look at advanced care planning, or ACP, as a process. Now, this comes from a model of advanced care planning that I'll introduce to you a little bit later. called Prepare for Your Care. And this definition comes from the creator of Prepare for Your Care, who's also the source of this, Rebecca Sudor from the University of California, San Francisco. But her team defines this, which I think is probably the best definition of advanced care planning, as a process that supports adults of any age or stage of health in understanding and sharing values, goals, and preferences in regards to current and future decision making, and also hopefully prepares them to communicate that. This is a hard thing for individuals to do, and yet necessary. We tend to plan so many portions of our life as well, whether it be, and let's say more so the happy moments, birthdays and weddings and births of children. And there's certainly planning that goes into perhaps funerals as well. But it's the in between where we're not exactly sure what's going to happen, where there's a need for most amount of planning. So, why is advanced care planning important? There's a number of studies that really have, over the last 15 years, have indicated a number of different things. Certainly, it improves patient satisfaction with care. And this is before, again, an individual might be actively dying. They could have been diagnosed with a chronic illness. It might improve their quality of life, mainly because their decisions would be honored. Sometimes an individual wouldn't want certain treatment. Improves what's called goal concordant care, a fancy term of here are my goals in life, here are my values, and the care that I receive connects, is in sync, is concordant with those goals as well. As an example, perhaps a goal is within the scope of my care to always have a faith-based presence in mind, whether it could be a chaplain or it could be music. And so that is integrated into one's care experience, because what's valuable for me or a goal of mine is to integrate faith into my life. And so that's concordant with the care that's provided. That wouldn't have occurred necessarily unless there was some sort of advanced care planning discussion or conversation. It also tends to improve the relationship between the surrogate, so let's say the family, the decision maker, and the clinician. Oftentimes, if decision making capacity is lessened, and certainly there is a less amount, I'm not going to say a zero, but less amount of stress on the decision maker. Knowing what their loved one would have wanted to do, perhaps honoring their wishes if possible. In the event that the patient passes away, knowing post death that the best care was provided in accordance with their wishes. And so advanced care planning has a number of different important factors, and yet the realities of it are a little bit more staggering. Over the last 10 years, about 33% of adults in this country, adults, have had any type of advanced care planning conversation. Most of those individuals are over the age of 65 and perhaps even older. It's certainly a lower percentage for racial and ethnic minority populations who have had those conversations, perhaps because of access issues or a willingness based on cultural norms to not have these discussions. But even smaller numbers discuss their wishes with clinicians. And so, and that's, we're talking about a clinician, let's say a regular relationship. Oftentimes individuals are waiting for clinicians to bring it up, but it's pretty apparent clinicians are not comfortable. They don't have the time, and they don't understand the process of it as well. All those things really minimize the ability for advanced care planning conversations to occur. Surprisingly itself, and I think this is the Block article, for individuals who pass away, who die within the intensive care unit, Less than 20% of those individuals who are really sick have never had, or around 20%, any type of advanced care planning conversation before they die. Now, that's staggering because those individuals are in a very different state. And so, with that, I'd like to point out a few of the um, sources that I'd like you to check out within this module. First of all, this is one of the assigned readings from the Journal of the American Gerontology Society speaks about the place of death for individuals with or without cognitive impairment. And the place of death is important. Consistently, individuals, when asked, whether it be in formal research studies or informal surveys, where would they prefer to die? And Americans would prefer to die at home. And yet, this research points out the discrepancy when in at least where individuals do die. But what I think is most interesting is the categories with or without cognitive impairment, because if there is some sort of cognitive impairment or elements of it, dementia, Alzheimer's, then a surrogate decision maker has to speak for those individuals. Not all the time. Individuals with dementia and Alzheimer's can still be included in decision making and should be. But certainly, it highlights, this article, the use of other options of care, such as palliative care and hospice. So I'd like you to really focus on this and check this out because it is connected to this quite well. One of the other items which I think is important, and I'd ask you to watch if you have not already, is the documentary entitled Being Mortal by Atul Gawande. Introducing Dr. Gawande, who's a surgeon and a writer. This is actually his book from 2014, I believe, 2013, 2014, entitled Being Mortal, bestseller, and a few years later turned into this documentary. It's about 58, 59 minutes long, but it really depicts the challenges associated with end-of-life care by following the patients, including one very personal to Atul Gawande, and also the challenges. It comes out with the notion that advanced care planning and conversations need to occur. There's also a survey that I'd like you to take, ask you to take at the end of this, that you'll be able to really reflect on what you saw in the documentary. And the last part that I'd like to talk about is prepare. This is a website. Again, as I said, Rebecca Sudor's team at the University of California, San Francisco, developed this as an instrument for individuals on their own to engage in elements of advanced care planning and perhaps even create an advanced directive. We're using this in our work, and I would ask you to go to the URL here, not just and to really go through the Prepare site, start at the beginning, and walk through it individually. And at the end of that experience, to again take another survey of what you learned in this exercise. And so this should probably take you independently, maybe a couple hours, and to go through. It can be done in your own time. I think you will find it beneficial as well, and something I also believe that many of you will think you might want to share professionally and share personally as well. So the module this week not just has content in it and some reading, but some activities. And this activity is, I think, both professionally and will be personally beneficial. And I am very interested to see your survey results as well, and what you think of not just being mortal, but prepare for your care. As usual, let me know if you have any questions about anything along the way. Okay. Thanks very much, everyone.